Hi, everybody. My name is Jamil. So I operate Ocean Regenerative Medicine. We're the Regenix affiliate clinic in South Florida, in the Miami area. This talk is percutaneous ACL, PCL regeneration, and meniscal connections. So why develop a percutaneous regenerative ACL technique? Well, as we all know, reconstructive surgery of the ACL does have limitations. Early onset of arthritis, sometimes the angulation of the reconstruction isn't right, can actually completely inhibit return to full play. So the idea of developing a regenerative technique that was minimally invasive came through the work of, largely through Dr. Centeno and Dr. Schultz here in Colorado, where I did my fellowship training. This is a diagram put out by Dr. Centeno talking about some of the limitations and the benefits of developing a percutaneous approach to ACL reconstruction with regenerative work. I'm going to present just one MRI case here to give you kind of a visual. It's nice that we had the case report just a few minutes ago about the full complete ACL tear. This is a patient who came to me. She's a 30-year-old female who had an MRI read in the upper left-hand corner as a complete ACL tear. So she called me. I just finished my fellowship actually at the Centeno Schultz Clinic. And I was taking a phone review, and this 30-year-old athlete, she's a gymnast, she calls me, and she asked me to look at her MRI. She said that she has a lot of her athlete colleagues who have had injuries and didn't get good response to surgical reconstruction, and she wanted to make sure that she could get the most technologically advanced care at the time. So I looked at her MRI, and my own work with the complete tears had been leading me to send them to surgery. Actually, at the time I was sending my complete tears. Then when I really didn't see a lot of fibers intact, I was telling them, look, I haven't had a lot of success with the complete tears. For a high energy impact athlete, go get the surgery. She said to me, look, I really don't want to do it. Is there any way? And again, I said, I don't think there is. She said, you know what? I want to come out there. I want to do it anyways. So we worked it out. I gave her a nice discount on the cost. She was getting married in a few months and just wanted to make it easy for her. Didn't feel like it was going to be a successful treatment. So, tried to make myself feel okay about it. So she comes out to Colorado. We do the BMC injection into the ACL. And as you can see, there was, when I looked at the MRI, there was just nothing there. It just looked like a complete mess of frayed, torn, nothing intact. And I used this technique. So this double bundle ACL technique was something I'd begun to work with maybe about 6 months before. I was still kind of refining it and working on it. And I said, let me try it here. I'm going to try the double bundle technique. I'll see what we can get. Just get as much flow, just dump as much BMC in along these insertional and origin points that I've found. And lo and behold, she writes me a month later, I feel great. Knee feels great. And I'm thinking, cells went in there, they stopped the inflammation, she feels great, she doesn't have an ACL. I'm still telling her, like, no, don't do exercise, just take it easy, let's get the MRI and see what happens. Well, she gets the MRI 3 months later, and lo and behold, she has what looks like the scaffold of an ACL. There it is in the bottom right. And I myself was shocked. I did not think it was going to work. And she's like, hey, the results came back. The radiologist is reading it now as like a partially torn ACL with a chronic degenerative component. And I was like, wow, yeah, that's pretty amazing. She's like, what should I do? And my work in Colorado with Dr. Pitts, he's a colleague of mine, a friend. He'd done a lot of great work with the ACLs, along with Dr. Schultz and Dr. Centeno at the time. And we'd kind of come to the conclusion that these high-impact athletes, doing a second round of BMC is the best way to get them back to full function. Because you do the first round, you get something like this. You get a regenerated ACL. It's not fully intact. The measurements of the tibial shift, I didn't include that on this slide, but those of you who are working with the BMC and the ACL technique, you know how to do the measurements. Even then, sometimes it's hard to say when it's a good candidate or not and when someone's really ready to return to play. So I had actually transitioned away from my time at CSC at that point in time when she wanted to do the second round, and she went to see Dr. Pitts. And Dr. Pitts did a second round of BMC. And as you can see in the upper left-hand corner, there's her MRI after the first round. And you can see on the bottom right, the ACL looking much healthier now. Nice, normal-looking signal. Red is a normal MRI by the radiologist. She's doing fantastic. When she came to see me, I told her, best case scenario, she could do some gymnastics in the backyard with her friends with a trampoline maybe. And now she's going to the national gymnastics competition She came to see me recently. I did some SCP along the sheath just to kind of tune her up for that. And I think this is a perfect demonstration of what is a complete tear. You know, this is where the idea of bringing in the MyEye and just really looking, because with the MRI, sometimes it's hard to say what exactly has continuation of the fibers and what doesn't. But this is a good example of just the potential for using these very highly, very, very refined, targeted techniques percutaneously can do. I mean, it's a perfect example of the potential of kind of changing the whole way we approach these. So this is just, again, from the beginning, upper left, complete ACL tear, nothing there too. On the bottom, MRI radiologist reading is a intact, normal-looking ACL, doing great. You know, doing flips, cartwheels. You know, something that anyone without a knee injury, you know, would still not want to do. So the anatomy of the knee. So this is basic, just overview. We'll go through this. So everyone knows, most of you here are orthopedic physicians to some extent, whether you're PM&R trained, orthopedic surgery, or family medicine, or somehow got involved in sports medicine. So the ACL originates at the medial aspect of the lateral femoral condyle, inserts on the tibial plateau. And it structurally reinforces the medial and lateral knee. And this is something I'm going to talk about later. And I think that as we develop the field of regenerative medicine, understanding like fascial connections and ways that tissue interact anatomically that we don't normally look at, because, you know, we go through medical school, we do our dissections, we clear all the tissue, and then we see the individual structures. But there was tissue that was connecting structures. And I think beginning to understand that the ACL does, in a way, reinforce the inside of the knee, and the PCL, in a way, reinforces the outside of the knee, and deeper connections, and we'll talk about it in a little bit, but just beginning to get the idea that these are scaffolds. This is the hinge joint. This is where the knee is opening and closing. It's opening and closing off of these deep cruciate ligaments. The anatomy of the ACL, again, this is a demonstration of how the fibers of the anterior medial bundle and the posterior lateral bundle change in orientation with flexion. And this will become important in a little bit when we talk about the contrast flow patterns of looking from a lateral perspective at the origin and insertional bundles of both. Again, this is a nice diagram that I pulled from Dr. Centeno's slides, showing the insertion of the anterior medial bundle and the posterior lateral bundle, then inserting up onto the medial aspect of the lateral femoral condyle. And again, all of this is going to be important when we talk about this presentation. This presentation is a way to share with you an accumulation of 3 years of work of myself and 10 years of work before from Dr. Centeno and Dr. Schultz, Dr. Pitts, Dr. Markle. A lot of guys have been, you know, really key in doing this. So this was not a one-man show. This is all of us kind of working together at CSC and putting together something cool that we want to share with everyone to really just help patients get better. So this is what I came into at the Centeno Schultz Clinic. Dr. Centeno and Dr. Schultz had brilliantly created the idea of a field goal post. They said, hey, Jamil, this is how it works. You got a field goal there, kick it right through the uprights, put it right there, and shoot some contrast, you're going to get the ACL. Well, I had a lot of trouble with this my first 3 months of training. It was hard, and I didn't get it until I figured out what was called the hub shot. Now, anyone who's an interventionalist here, if you don't know what the hub shot is, I'm sure you do. And if you haven't perfected it, my humble recommendation is do it as soon as you can. About 3 months into my training, once I figured out how to line the needle straight down the beam and shoot that target, I began to develop the accuracy to pinpoint anywhere I wanted on the fluoroscopic image. And we're going to talk about that more, because everything you're going to see here in this approach, which takes a very complicated injection and turns into something you can learn in this talk. If you follow this, you will do your double bundle ACL insertion origin. Watch this lecture, try it, and you'll get it, I promise you. It's very simple when it's diagrammed. So this is what Dr. Centeno and Dr. Schultz were doing for years. They were doing it. They were doing a great job. They had been working with the double bundles, but there was still a little bit of room for improvement in really being able to isolate it and reproduce it again and again. This is a nice contrast flow showing clearly on the AP view corresponding to a coronal view on an MRI, the nice fibers of the ACL going from the tibial plateau to the medial aspect of the lateral femoral condyle. So the idea to modify, why did this happen? Well, we worked really hard in this clinic. So CSC, these guys work 12, 13-hour days routinely. We get our Jason's Deli lunch, And as I was eating my salmon salad, every day for a few years, I would just stare at the wall of pictures that I would, get from Dr. Schultz or Dr. Centeno or Dr. Pitts or Dr. Markle or Dr. Williams or whoever was there, Dr. Heisey. These guys would just pass me pictures, put them on the wall, stare at them. And just as you stared at these pictures, I started noticing patterns of flow. Oh man, if I got it right there, that's how that one got there. That's how that injection went into the ACL and then into the anterior horn of the medial meniscus. And this wall eventually got completely covered and just, again, kept staring at these things every day, just looking and, okay, whoa, yeah, kind of like that kind of thing. And just trying to develop this idea, let's see what we can do and shift it up and develop a new technique. So again, you have to use the anatomy to really begin to understand this technique. The anterior medial bundle and the posterior lateral bundle insert on the tibial plateau. Those are the insertion points. One being more medial and more anterior, hence AM and PL. And as you can see, and we'll touch on this later, connecting to the anterior horn of the medial meniscus, almost in that picture, that black half oval almost does connect to the anterior horn of the medial meniscus, and I'll show you later why it does. And the posterior lateral bundle connecting to the insertion of the anterior horn of the lateral meniscus, and then vice versa on the origin, the anterior medial bundle and the posterior lateral bundle on that point, exactly on the medial aspect of the lateral femorocondyle. So get those points in your mind, because those are your landmarks, and that's what we're going to show you how to do right here. So the double bundle fluoroscopic schematic AP view. So this is just showing perfect placement of the needles. Bottom left, arthroscopic view of anterior medial bundle and posterior lateral bundle. The top showing just some anatomy. And the bottom right is a nice representation of what we can do. And if you look closely, you can see both bundles there clearly delineated, dropping down the hub of the fluoroscopy straight onto the points that I'm going to show you, and then reproducing it. So how do we do this? Well, first is setup. Anyone who's involved in regenerative medicine knows preparation is 101% of a successful procedure. Whether it's getting the fluoroscopic view exactly right, whether it's getting the patient's limb exactly right, or whether it's getting the biologics on the tray preordained in your mind. This is going to the meniscus, this is going on the femoral condyle, this is going into the semimembranosus tendon. Because once you get it all organized and you get everything set up, you're flying through the procedure and you're able to do complex work in the amount of time that you're going to be able to have to work with your patients and have an effective practice. So we start with the patient placed in a hook line position with the sole of the foot placed with an angle of the hips and knees at 90-90. So this is the hook line position. So this is what I was taught by Dr. Centeno and Dr. Schultz. A very brilliant way of getting to that tibial plateau under a caudal tilt of the fluoroscopic beam. So depending on the placement of the patella, this one's important because like I said, if you follow this schematic, this PowerPoint, you'll be able to do this in your office. So what happens if the patella is low? Okay, if you have patella baja, you can't slip under the patella to the tibial plateau. This took me like a good 6 weeks to figure out how to adjust for this. But what you can do is you can either increase the caudal tilt. Normally you'll start at like 15. So if you increase to somewhere between 15 to 25, you'll slip the patella up. And that space will open up again to view the exact points that I'll show you in a second to get from a hub shot straight onto the tibial plateau. Or you can decrease the angle of knee flexion, which will also move the patella up on that caudal view, which more or less looks like an AP view because the patient's joint is caudally tilted in alignment with the caudal tilt of the fluoroscopic view. So first thing you want to do is you want to divide the tibial plateau into 4 quadrants, okay? So take that beautiful looking field goal and shift it to a football on its side. We're just going to kind of flip reality for a second. Divide it into 4 quadrants and place a mark in the upper medial quadrant is the placement of the hub shot for the insertion of the anterior medial bundle. So again, if you know what a hub shot is, you can follow this reasoning. If you don't, talk to one of your colleagues, say, what's he talking about? How do I get a perfect hub shot every time? And it takes time. Get the needle in, adjust, and then advance once you get the hub shot. Don't try to advance in the tissue and get a hub shot. Advance superficial, do that superficially, then go deep. Once you have that hub shot and you line up superficially at a hub shot on that point, 180, 180, 180, 180, corkscrew the needle down to that exact point. And that's for the insertion of the anterior medial bundle. Posterior lateral bundle is right there. It's the kind of the inferior medial border of the two right quadrants. And that's where the posterior lateral bundle insertion point is on the hub shot. Again, when you're thinking about the insertion from the diagrams, realize that there's caudal tilt, there's a little bit of flexion, so things are a little bit different. You can't exactly map this to the anatomy, but these are the points. Just kind of follow the thought process. So placing the needle in preparation for a hub shot targeting. So what you want to do as you're learning is you go through and you get better, you'll be able to quickly just put it there, take a shot, drop your lidocaine, and know where to go through. But this is what you do. You get that opening, you open it up, and you take your needle, and you put it on those 2 points. You shoot a shot, line up the tip of the needle at those 2 points on that 4-quadrant diagram, line it up on those 2 points, and then place 2 dots. Get a surgical needle and just put it right there. Because if you do a hub shot down that point, that is that blue dot, you will land on those 2 insertional points. And every single time, you will reproduce a double bundle insertional procedure, like clockwork. And this is it. This is what happens. You get that flow. Placement of the needle in preparation for hub shot target and double bundle ACL insertion. Contrast flow of both anterior medial and posterior lateral bundle insertions from properly placed needles. And that will happen every time. You get it right, you'll notice it. There's going to be a little variation. Sometimes when patients have strained ACL, you'll see that kind of osteophytic change coming up the tibial plateau, and there may be a little bit of movement up and down from that quadrant point to adjust for patients' knees who have changed a little bit of normal orientation. But more or less, this is a very reproducible way of getting these 2 bundles. So how about the insertion? Well, the ACL insertion, again, is on that point at the medial aspect of the lateral femoral condyle. So we have the origins. You'll see the contrast flow up. But where's the tear? Maybe it's a proximal tear. Maybe it's a mid-portion tear. You want to get complete coverage of the ligament. Now, here's a nice shot of a lateral showing the anterior medial bundle and the posterior lateral bundle. Now, the knee in a hook line position is not quite in flexion, so the fibers don't exactly cross into that switched orientation that they do, but you can see them beginning to. And I'll show you that when I show you another slide, that there is some movement and twisting of those 2 bundles at this point. So how do you get the insertion? This is something I was taught from Dr. Centeno and Dr. Schultz. This was not something that I kind of worked on, but something they gave me. With the medial aspect of the lateral femoral condyle, you line up the needle, you just drive it up. You start low and you drive up towards, on the AP view, towards that point on the femur, on the femoral notch, on the medial aspect of the lateral femoral condyle. Then you switch to your lateral view and you'll be at those 2 points. If you need to go higher or lower, that's how you catch the individual bundle insertion points. And you shoot the contrast view. So here is the point on the femur where you find the origin of the 2 bundles. This is again from Dr. Centeno's work. Now, working with this, one day I was working actually with Dr. Qureshi in Texas. I was doing some consulting there, and we started to look at the posterior aspect of the knee. Okay, and I just had the idea. You know what? Let's see if under ultrasound we can drop down and find the back of the origin of the ACL. Let's just see if it's possible. No one had done that before. A lot of guys say they can do it under ultrasound. Let's see what we can do and match it with the Flouro. And lo and behold, it was like like finding like $1 million in the street. Just boom, dropped it in, and lo and behold, there it was. Just kind of came in from behind, used the ultrasound, maneuvered around the nerve and the vessel, and dropped it in and shot some contrast. And both bundles there in the normal orientation, not in flexion, so you don't see any twisting of the fibers. Just like you were looking at like a sagittal MRI, right? You can see them. They're right there on top of each other. I was like, wow, that's cool. Let me try that again. Well, again became like 5, 6, 7, 10 times of not being able to do it. Just got super lucky. And I was like, how am I going to do this again? I know I can do it. So started working with this other approach. Now, this other approach, do you need to do this? It depends. It depends. If you have a really, really proximal tear, I think this is probably the best way to do a really, really high proximal tear, because from the other diagram we were showing you from the AP approach, it's hard to get into that upper part on that shot. The needle, you have to snake the needle back, and to find it up there, it gets hard. This one, you come straight in at the origin. You're in the notch. You're high in the roof of the femur, where a lot of the fibers of the origin, the ACL, are. So started to work on this and started to realize that there is a way to line it up and reproduce it and improve the reproducibility of this procedure, and it's all about setup. Again, it's all in the preparation. Anyone who's in regenerative medicine, just take 10 minutes before your procedure to set everything up, and you'll finish 20 minutes earlier. It's all in the preparation. So what do you do here? Well, first thing you need to do is in the bottom left, you need to find that point on Dr. Centeno's diagram on the medial aspect of the lateral femoral condyle where that oval is, because that's where you want to get the needle to ultimately under ultrasound matching it to Flouro. So thank you to Ryan. This is my operations manager. He was kind enough to let us shoot a bunch of x-ray. You slide the other leg off of the table so you can shoot a lateral, and then you line up the needle, put it to the side of the knee, and then 360 a line around, because you're going to switch to ultrasound, because you have to go under the nerve and the vessel, and you're not going to do that unless you use ultrasound. So from there, this step is crucial. Remember, don't forget this. This is going to allow you to draw the line on the knee, so when you switch to ultrasound, you're in that plane. And that's what you do. You find that plane under ultrasound, and you come in deep from the medial approach, and you come across, and you can see in that diagram, the lateral femoral condyle is there, so dipping deep, you're at the ACL origin from a posterior approach. Only do this if you're super advanced. I really, the nerve and the vessel are there. You have to really be able to visualize your needle, or you will really hurt someone. So, disclaimer, this approach should only be used by a highly adept MSK ultrasound interventional practitioner. And it's going to take time when you start working at it. This is not like the other insertional bundle approach. This one's hard. I'm still working on kind of, mastering the reproduction. I'm getting a lot higher percentage of being able to kind of drop in there and organize it and set it up, but I'm still not 100% able to do it on the first time reproduce it. I can play with it and kind of get it, but there's still some tweaking on this approach that needs to be done. So moving to the PCL. So PCL, why do we need a double bundle PCL technique? Well, why not? The PCL has two bundles, just like the ACL, and they insert at different points on the knee. There's the posterior medial bundle and the anterior lateral bundle, which we don't really talk about, but we should, because each of those intersects with a part of the posterior roots of the medial and lateral meniscus, which forms the crux of the knee. And that's the second part of this talk, and I'll try to breeze through this in the interest of time, is to understand how the meniscus inserts on the cruciate ligaments and to present kind of a new idea in the field of regenerative orthopedics, which may sound a little bit crazy, but just open your mind to fascially it's all connected. And when we go through anatomy, we dissect things, we're dissecting things that are actually in the human body interconnected. So this is a contrast view of the double bundle PCL technique, which you can also do. You can start teasing out the double bundle of the PCL and then treating posterior root tears in the medial lateral meniscus based on the MRI, depending on which bundle you want to find. So you can get more and more advanced and increase your efficacy and increase your patient outcomes, and you will. The more you do this and the more you're able to isolate the individual bundles and really treat the individual finding on the MRI or the physical exam, you will improve your outcome. So again, it's all in the details of preparation. So you line the patient up, AP view, lining up the needle, putting it across. That's the ridge in the bottom right of the tibial plateau. Vessels are above, line is there, drawing a line across, and then coming in laterally underneath those vessels, placing on the blue line that you drew from the AP, you marked your line, so you know on the ultrasound you're coming in this place, and coming in underneath on both sides and hitting the two bundles that way. This is, again, is something I'm working on a lot, and I don't have 100% reproducibility of this. If anyone works on this and further develops it, these techniques take years. The ACL techniques took basically 3 years to develop. I'm like a year and a half into this. Definitely could use some help. If someone starts working on this, I'm going to put my email at the end. Shoot me an email, shoot all of us an email, let us all kind of advance this field together. Because this is cool stuff when you start really getting refined with the percutaneous isolations. So visualizing the new technique, this is the origin approach on the ACL with a double bundle. This is a patient I treated for a posterior root meniscal tears in the face of a proximal ACL injury. And as you can see, you can get real sophisticated with this stuff. You can really, really start placing it and getting much, much higher outcomes. So meniscal connections, we'll finish up this quickly, but this is really interesting stuff to think about. So the ACL attaches the anterior horn of the meniscus via the transverse ligament. This is kind of written in orthopedic anatomy books, not really questioned. Now, this is what I talked about before, the anterior medial bundle attaching the anterior horn of the medial meniscus the posterior lateral bundle attaching the anterior horn of the lateral meniscus. And once you get those insertional points on that quadrant, you will be able to play with that needle and just play with it here and there. If you wanted, a little advice on how to do that, just contact me, I'll let you know. But you can twist that and find those insertional points and get contrast flow along the medial meniscus. So there on the left is showing how the medial meniscus filled from that anterior medial bundle. And I'm sorry, on the right is the medial meniscus anterior horn filling from the anterior medial bundle injection. And on the left side, the anterior horn of the lateral meniscus filling from the posterior lateral bundle. And again, that's playing with that quadrant technique. So meniscal connections. So this is an article I found, paper number 276 from our friends in Scandinavia, who published this very obscure article, which is pretty awesome. And basically what they said is, hey guys, the PCL also attaches to the posterior roots of the posterior horn of the medial and lateral meniscus. Why aren't we talking about this? They did 100 dissections and said in 100 of the 100 dissections they did, this was a connection they saw in all of them. They named this the fascicular menisco-cruciate ring. And this talk, as I'm going to finish up, is just putting a theory out there that that's on both sides of the knee, that the menisco-cruciate ring is on the anterior part of the knee and the posterior part, where the anterior medial bundle, posterior lateral bundle, and posterior medial bundle and anterior lateral bundle of the ACL and PCL respectively insert on these meniscus. Again, this is same kind of diagram showing, finding those points, filling the lateral and medial meniscus from a posterior approach, playing with the insertion on those bundles that I'm still working on. Again, this is a work in progress too. I'm still trying to find the exact point. But you can find it, and you get perfect flow into the roots, and you can get to those root tears percutaneously. So this is a diagram just kind of illustrating this idea. You're going to see a bunch of drawings come up, so let it pop up, boom. So you see, that's what I think we're missing in these anatomy books that we have that weren't written by regenerative orthopedists, which, when we start writing these, Dr. Williams is writing a ton, and we're going to get some guys out there really starting to put some of this together so everyone can benefit and we can get patients better. This is a diagram that I hope is in a book one day. So this is showing the bundles attaching to the medial and lateral meniscus in a different way, showing that flow pattern along those individual bundles into the anterior horns and the posterior horns of the meniscus, connecting the dots, showing that you can do that. You can hit percutaneously all those points on the individual bundles of the ACL and PCL, and then connect the dots of the menisco-cruciate ring anteriorly and posteriorly, completely regenerating the meniscus, which I'm going to, create a hypothesis, which is essentially an extenuation of the cruciate ligaments, which creates the hinge joint as the cruciate ligaments come from the roof of the femoral notch onto the tibial plateau, creating the hinge joint, creating the mechanics of the knee. So this is a diagram kind of illustrating what it would look like three-dimensionally and just showing an idea. The knee is a true hinge joint. Understanding this complex connection is key to successful ACL, PCL injury regeneration. It also has implications for deepening our understanding of medial and lateral meniscus repair, which we've talked about, as well as knee OA regenerative procedures. Now this, I'll just speak for a minute on this. As you're working with your knee OA patients and you notice on the MRI that there's some meniscus remaining, start thinking about these individual bundles, the ACL and PCL. If you can't get denuded femoral condyle to regenerate, fibrocartilage does seem to regenerate better with the BMAC. So teasing out the anterior medial bundle or the posterior lateral bundle and being able to regenerate the inside or the outside of the knee in conjunction with your treatment of medial or lateral arthritis. There's not a paper that says this, just anecdotally, case series. I'll tell you this does work. When you start looking at the knee this way, you're going to get higher outcomes. And I think that's what we're going to start seeing as this field develops and we get more refined in our techniques, that we'll start talking about these things. And we'll look at these research papers that are coming out where they didn't individually hit a bundle or they didn't individually hit an insertion on the meniscus. We're going to be able to say, well, that study didn't isolate the anterior medial bundle when it treated the anterior horn of the medial meniscus tear. I didn't see a contrast flow. They didn't reproduce that. That's why they didn't hit that transverse ligament connection. And that's what we're going to start doing. We're going to start getting really refined with the anatomy, and we're going to really advance this field. Next is Dr. Dallo. Had a great conversation with him. Loved his video on LinkedIn showing the arthroscopic approach. Want to study arthroscopy more myself with the MyEye. And I think there's definitely a room for surgeons and interventionists to work together. There's no reason not to. We all just want to get patients better, and that's why we're all here. So thank you. I think I went into like question time, but.
Do we have two good questions for Jamil? Questions from the audience? There's one in the back. He needs a mic.
Hey, so how soon after her injury, the gymnast, did you inject?
For the second round?
For the first one.
She was within like a month. It was very soon, yeah. She had the injury. She got on the net. She started looking. She made contact with us. She wanted to get out there right away. Very, very into her body, into her health. Yeah, very, very soon after.
And so when you did your injection, your contrast flow patterns, so.
Yeah, my contrast flow patterns. My insertion did go up. I got the insertion up to 2 bundles, but my lateral origin injections weren't looking that great, and her tear was like, kind of up into that region, a large part of it. So that's why I was skeptical of the outcome. And like I said, when I got the result, I was, it bent my mind. Traditional, allopathic medication, education. I still, as an interventional orthopedist, I'm still kind of like, surgery's the right way. I'm still like bending my mind every day because that's how I was taught to think for, 4 years in medical school. So I was shocked when it worked myself. So yeah, contrast flow looked okay.
Okay, thank you.
One more right here.
Thank you. And the posterior approach, are you using a true lateral, or are you orbited a few degrees, or is it patient specific?
No, it's the AP. You're shooting. You're shooting a lateral. It's a true lateral, yeah.
On the diagram,
it's a true lateral on the diagram for the ACL posterior approach. Yeah, then you are doing a lateral. It's a AP for the PCL, but yeah, it's a true lateral. It's that diagram on Dr. Centeno's, that oval. You just line that up on the, because you have to know where to go, and if you're going to go from ultrasound to Flouro, because otherwise when you start working with ultrasound and you haven't drawn that line, it gets crazy. You're like high in the notch or up on the back of the femur, so you really have to spend a lot of time setting it up. Yeah.